Great. And now lay on your back.
Lunge.
Down to here. And now I could come in here and just have a look at this and have a look at that. Lay on your stomach. Have a look at this and have a look at the prone knee bend in that position like this. And then I would go on to looking at the back. So this is not going to take me any length of time to do. But I'm thinking of this as a dysfunction. The whole of her history seems to suggest dysfunction and not derangement. And so I just want to be sure that there is nothing else going on here. Now then, if she's also complaining not just of pain here, but that when I watched her walk it looked a little bit difficult, I could ask her to go down into this position and up, which would also check the quadriceps, but it would also check the amount of movement that she's got in the hips and the knees and the ankle. And then I would go on to an intervertebral joint motion by coming here and seeing I can focus where it is, and then I would investigate by intervertebral joint motion. That would be the way that I would look at this kind of a problem in Sandy, which looks to be dysfunctional. There's not a lot of referral. I'm not going to spend ages and ages spending a lot of time in the legs to start with. But I do need to know what the neurology and what the nerve conduction is like, even though I would doubt that there would be anything positive. Okay, I'll do the next one on myself. The next person comes in and they're deviated like this. All right, so what do I need to do here? Well, perhaps Sandy can stand up now and deviate. All right, now I'm going to be in a really difficult position here, but what I could say to her is, look, I know that this might not be very pleasant for you, but I just want you to do it because it's very important for me to know. So I'll just hold you in this position, and I'd like you first of all just to come up onto your toes. Just leave your deviation where it is and down again. You don't have to tell patients that, they will. Let's have a look at this. Okay, that doesn't seem too bad. Don't drop down quickly though, just sort of calm down slowly so you don't jar your back. Okay, let's try it on one leg now. Keep this position, and I'll just hold the deviation so she doesn't hurt herself. Try the other leg. This one? Okay, so she comes up and down like this. Now, would you just walk on your heels a minute? Okay, so we've got perhaps no neurological implications. Could you just lift one leg up a little bit? Here? Just hold on to the side of the table there and just let me do the reflex in this position, the reflex in that position. I know that the chances are that the quadriceps affected are very kind of rare in this kind of case, so I might not even look if she was having a lot of problems. I could have a look at the straight leg raising in this position by just saying, hold on to the table for a minute. Now, can you let your leg go forward and down, and let your leg go forward the other way? And okay, where we've got some restriction, let us say. So now I'm going to have to sort of bear that in mind as a test. Now, I may go straight on from that to looking at this and starting to treat. This is one of these cases where the worse the patient is, the less you can do with the examination. But you need to have something in your mind, the absolute priority. And that's about the saddle anesthesia. That's about bilateral symptomatology. That's about just checking up that there's no loss of reflexes on both sides, that kind of thing. Or that we've known neurology, and then I can go on to correct. So now I'm into my position of being able to sort of say, now, what we need to do here is just let me pull you across, but if there's any spread of pain into your legs, you've got to let me know. And I would follow that route with this particular patient. Now then we go on to our full-scale thing. As far as the Cyriax examination is concerned, and it's not probably what many of you are doing, you're probably doing far more than Cyriax. We've got the subjective analysis. I should get Anne to do this so you see the absolute perfect thing. But she can criticize me if I do it wrongly. Okay, because I forget too what it included as well. We will go into the active ranges, or the architectural design, and I would look at the, for leg length. Can you just put your... Haven't you heard about skin cancer? Okay. Okay. So I could look at the architectural design, posterior suprailiac spines, iliac crest, come round to the front. I could look for whether there's any deviation, and I could just sort of gently palpate in the back here. Next thing I could do is to ask her to do the movements. If I've got no reason for knowing which movements are painful, I would probably do side flexion first. and the other way, just to give an idea. If both side flexions were very restricted, you know, we have to think a little bit about things like ankylosing. Come back a little bit, and then go forward. Okay, come up again. So I could look at that and I could make my diagram. Can you twist? This is quite useful as a hip test. I'm not so sure it's great for a back, but we can also do it sitting down and come the other way. Okay, now, as far as Cyriax was concerned, the next thing that he went into was doing his only example of muscle. Can you pull away from me? And he did a side flexion of the spine like this. And this had to fit in with what you did inside lying. Okay, then she could sit down. And I would look at the difference now in the height of these things for that leg length. Having done that, lay on your back. And I'm sure he's going to tell me if I've forgotten anything or done anything wrongly, so I want you to do that, Anne. We'll just get the leg down here. What did Cyriax do for the sacroiliac joint? Just one thing. That was this one, which was compression and distracting the back of the joint, distracting the front of the joint.
How long do you need to hold those?
I think in Cyriax's terms he just did them because all he was interested in was a medical condition at the sacroiliac joint. He didn't really believe in much else, he said in his book. However, he used to send quite a lot of patients upstairs to see Barber, who felt that 50% of all back pain came from the sacroiliac joint. So, you know, Cyriax did cover that, but not in his own particular practice. But as far as this as a test for hyperirritability of the sacroiliac joint in terms of something like ankylosing spondylitis, it will come on straight away. Okay? As a test for what the anterior part of the joint is doing, posterior, you'd have to hold it for longer. We'll talk about that tomorrow or the morning of the next day. Okay? Now then, when he went down the legs, this is what went on here. Can you just come up here? I'll just go into a medial and lateral rotation movement. So this would be a movement for the hip on both sides. Then as far as coming back here, I would look at, can you pull your leg up? For the psoas, come down to here. Can you hold this? For the quadriceps, I'd look at that movement as far as the knee is concerned. Then I would be down to the ankles, pull up and down in this position and downwards like this and down towards me. Now can you pull up here? And Cyriax was very careful with his L4. He stood from this side. When he compared it with that side, he went to the other side, did it exactly the same. Come to L5, can you pull your big toe back, the hallux? Can you go into the perineals and look this way and this way? If you've forgotten, like I've done, to do the calf, then you can come into here and push downwards. Push down here. Compare those. I can now look at skin sensation, L4, L5, S1, S1, and I can do S2 in a moment. Next thing that I should just look at is the straight leg raising, which I take up in its neutral position here. And down. I would compare that with the bent knee to look for the sign of the buttock, and I would come down. Can you lay on your stomach? I can check out the reflexes here, this position. I can come into here and make her do S1 again. Can you push up on your toes and down? We can go into S2. Can you pull up and let it go? Can you squeeze your buttocks together? So we can look at the L5S1 here if we've had difficulty in finding anything down below, or we have alternatives like 4-5. We can make her do a resisted rotation into medial rotation. If for some reason, you know, she got an arthritic ankle or something like this, which was affecting what L5 or 4 would do down here, then he went into the spine there like this, just did his palpation here, his posterior pressures, and last but not least, or it would probably come before that, I would have done the prone knee bend to produce backache, not just tightness in the anterior aspect of the leg, compared it with the other side. And hamstrings I've done, and just the skin down S2 down here. And that would be the Cyriax examination. That will tell you all of the things that we've done. But we've embellished this by so many things that it sort of complicates the route that we take. Now we're into a position to think, right, we've got this present or that absent. We've got this present, that absent. What other tests do we need to do now? And this is the stage, and it's taken you about 7 minutes or something to do that. So there are 3 ways that I would do my kind of modifications of the scan. For somebody that I really don't want to spend a lot of time because there's no evidence of anything in the leg. A patient that's like this, that I've got to be very careful about because I know that a lot of the tests are going to be a bit complicated because of the deviation. And the one where we've got back problems with some radiation down the leg. So we do need to do a fairly careful evaluation to make sure if there's any signs of difficulty with neural movement or difficulty in neural conduction. Did I forget anything there? Okay, Babinski and Clonus, okay, which would have obviously you pick up if you've got hyperreflexivity in these tendons, you then would go into here. But that's, thanks Anne, Babinski and Clonus. So here we go. Clonus, how many times would we get a clonic contraction for it to be positive? 3, yeah. Up to 3 is considered, after 2 I get a bit worried. 3 is the Clonus Society. That's what they sort of suggest. And of course, Babinski, which is a superficial reflex. Can you come off here? Okay, there we go. So we're just going to come around and have a look for the downturning toe reflex down here. Okay, good. So that was the Cyriax examination, that we've now got it so complicated that none of us really know what the original thing was. Now, are there any questions on that?
If PA is no reason to do rotation at this point.
No, I'm going to make my mind up now, because I think we've got inadequacies. All I know now is I've got a spinal problem, which we're calling dysfunction, and now with this spinal problem with dysfunction, we need to know now, where is it? Is it hypo or is it hyper? We certainly know that there are no neurological implications with this problem. And so this is where we need to go into the next stage of examination.
Is the only thing you checked on that exam and sitting just levels of the PSIS? That was it?
That was it. Now, there are certain things that I think we need to sort of think, could they go reasonably into the scan, which Cyriax didn't do. Not in total terms. In other words, when we look at the joint structures, for example, our quick little checks for peripheral joints, were they adequate? Can you lay on your back again, Sandy, please? I'm not sure, for example, that going into a hip and doing a medial rotation is adequate. It doesn't pick very much dysfunction up. I find, even with osteoarthritis, the fact that it is not in the capsular pattern in any way, this seems to be much more subtle in finding it, is to go into the Patrick Faber test, like this. And this would let me know if there's a hip or a sacroiliac joint that I'm going to have to look at a little bit more detail. I find this a better test as my quick check to see if there's dysfunction in this area. Anything else that is a better way of doing this? No, I think that's probably quite adequate. Then we need to sort of ask ourselves, what didn't he do? It was a bit painful when I went past 4. Now I'm going to examine around there in terms of intervertebral joint motion. Right, what I'd like you to do, just work in pairs, whip through this standard procedure, which you all know, so it shouldn't take you any longer than it took me, and then we're straight into looking at how perfect you are on intervertebral joint motion, which will be good, and we can get that, most of that done before lunchtime. Which means that in the afternoon we can get on to some of the sort of techniques of mobilization, which I want to do today. Yes, ma'am?
Where is the compression test and torsion?
To come up here.
Okay, was sticking to my
You're pretty good at that.
Now, If we could start using fairly standardized procedures here so that we continually get the same kind of feedback. Can you just lift up a second? So if you have a table that lifts up in the middle, like all mine do, that's fine. But if not, let's get this so that we into a fairly neutral lordosis and perhaps even a slightly flattened spine. When we are going into testing for hypermobility and we start looking for the Rosette test and the feeling at the end range, we want to be in the middle of the range, not with the lordosis so we're at the end of the range. This is exactly the same as if we took a joint, for example, let's say for an anterior cruciate, and we pulled it towards the end of its range, and then we saw what was at the end. It brings in the secondary restraints. We need it to be back in its neutral so we can feel it moving through its range to the end range. So let's try and get out of the bone impaction, or not impaction, but that sort of position of lordosis and go into this position. So as far as, just let's very rapidly go over the sort of finer points as I see it of these things. As far as postero-anterior pressures are concerned, okay, Maitland made a good point in terms of the push should be in the direction of right angles to where the curve is. If we flatten the curve, this minimizes this, but still to come slightly towards the pubis as we go over 5, a little bit less to 4, straight down to 3, as we go to 2, to gradually start to go in the position or the direction of the xiphoid. So that keeps us always pushing more or less at the same angle, accommodating whatever is the small part of the curve that we have there. Now then, I'm going to go into a side-lying position, first of all. Facing me, please. And this is very important once again, that we get the spine straight and that we do not have the spine in a side flexion to the left position, because all this has dropped down to the bed, because once again I've gone into the end range again and this will tighten everything up and I'm thinking, oh, this is pretty good, but it's because we're at the end of the range. We should be at the middle range before we start checking all of these things. So I would probably put a slight roll or something. Got to there? Yeah, okay. Just to sort of accommodate that. This becomes even more important if you're dealing perhaps with a female patient that is really quite wide in the hips. So, and has got a much smaller waist. So they really drop down towards the table and it can really confuse and mess up the system. Now, as far as I would be concerned in this position, we've done that position of postero-anterior pressures. I normally then go on to doing a slight anteroposterior glide, doing it like this. And what I'm going to do here is to push along the femoral shaft, but in the direction of what I know is the disc. So if I look at the lumbosacral angle, I'm going to be pushing at this, and I don't alter the position of the legs at all. I merely slightly alter my push through the legs, so that if I were at the top here, I would be pushing like this, and I would be pushing like that if I were doing the lumbosacral angle. So I'm just trying to visualize the angle of the disc, and I'm trying to produce this translation motion. So I'm just going to go up here and see whether I can feel just right off the bat any movement that seems to be excessive or stiff. I look up here and this feels a little stiffer. I come down here and somewhere that feels a little more motion. This feels a little less. So I've got to decide, is this greater than it should be and that normal, or this is normal and that's less than normal? So this is just a little focusing again, just coming in this direction there.
I guess I was under the impression you didn't want any motion in that, with that direction of movement. Why would you be trying to identify stiffness? Aren't you trying to find, do you want motion to occur?
Of course. You want translation to occur, don't you? Say I was looking at the, no, if I were looking at this, I would look for joint play. And translation is a form of joint play. It's just how much is it? Is it going back like this, or is it just a little give as I go up and down through that? So that's all I'm looking for. It's not excessive though, Brian, in this particular case. As I'm doing this, I can just feel that this is happening, just a little bit. If it's greater than that, it would be abnormal. Now, having gone through that, my next procedure usually now is to feel very gently over where I feel there is some, not excessive movement, but where the movement I feel to be a little bit. Any soreness there? Okay. No great problems there. All right. So, it's probably that this is the normal joint motion. So now what I'm going to do, I'd like this a little bit higher, but this is my height for me at the moment, is to go through some flexion and extension. All of you have done this, so we needn't spend a lot of time doing it. If you're going to use both legs, you don't have to worry very much about the position of the leg. If you're going to use one leg, you've got to keep the leg up in its normal position as if you were using two. You mustn't let it drop down, otherwise we're introducing flexion with rotation. So it's really important that you keep it up in the air like this, and we can just gradually move up. Don't keep moving up and down. Once we've gone past that level, we only need to come back just a little bit as I make my way up the spine like that, going into the flexion motion. Coming up here, I can in fact save all the stress on the lower part of the back by taking my hands to a higher level and just encouraging this movement and a little bit of a motion down here. This is getting very close to what I might do as a mobilization, but the techniques are the same, generally speaking, in the Norwegian system. Between testing and mobilization, it's just a matter of degree, so you can use pretty well the same techniques all the time. So that's what I would do as far as flexion is concerned, and we're doing a pretty normal flexion. Now extension is a more difficult movement to do, and so what we're going to do with extension is to cheat a little bit and use a little bit of a sort of a posterior glide with this, because we're going to try and increase the lordosis. Now I'll speak to you a little bit later about this. Lordosis and extension are not the same thing in every regard, but they are in some regards. And in this way, we can certainly push back a little bit along the leg there. So I'm increasing that motion of taking the spine from below, caudally, going cranially in that slight extension motion there. So I'm not getting the whole thing back and killing myself going back like this, which would be impossible for me to do, very uncomfortable for him. If I just increase the lordosis a little bit by just pushing backwards like this, this works perfectly well to test extension. We'll always pick up stiff extension, and I can work my way up perfectly well to about T12, T11 by just pushing, and I'm using my body the best I can with my leg and my hands coming through in that way, but I'm certainly trying, as opposed to that movement, to produce just that little bit of an extension movement. As you see, it's a slightly different movement to just my plain posterior translation.
So you're doing a combination of both?
A slight combination of both. Next movement that we can do is to do a side flexion. Now, a little problem here in terms of where the legs are, so I'm going to take the legs out to the edge of the table and work in a side flexion to the right by just dropping the legs down a little bit. Now there are two ways to do this. Either I can use the legs as a lever, which I usually don't do, I just leave them there, and I come much more into a short range motion like this and just do this kind of a motion here, so that I can partially stabilize and do a side bend by going through the iliac crest, and then focus on the individual vertebra as I move up by just getting my hands closer to them. So as you can see, I'm using this hand as my palpating hand, that's my left hand. I'm feeling in the spine into the interspinous space, and I'm just pushing down through here and getting hold of the the caudal bone a little and making sure that it's being lifted up into side flexion to the right hand side. And with the legs slightly off the bed, the weight of the legs will help the motion. But I like this short range stuff instead of coming in and doing this, which is taking in a whole lot of stuff in the hip joints and everything. And I think that this is more accurate. Now, if it's tested that way, then I think you've got to test movement to the left in exactly the same way by turning the patient over. If you've chosen to do it with the legs down, you've got to do it in the same way by going to the other side. The other way of testing side bend, of course, is to lift the legs upwards like this and just sort of palpate into space like this. But I'm not so keen on this technique because of the stress it puts through the knees and the bit of rotation it puts on the hips. I prefer, I must say, this very local technique of just coming around and just pushing in side bend like that. So you can see how that goes. Now, I think the question we've got to ask ourselves is it possible to have a restriction of side bend but not a restriction of rotation? I don't think it is. I think what we're looking at here, and this is a point that Bogduk has made quite frequently, that these movements that take place of side bend, we can't really think of side bend taking place across a sagittal axis and rotation taking place around a vertical axis on a horizontal plane, because both of them occur simultaneously. They are coupled. So what we should probably be thinking of is an oblique axis, so that any degree of side bend loss is going to be accompanied by an equivalent loss of rotation. So testing rotation and testing side bend are probably, in my sort of thing, the same thing. Although occasionally when we see one is more restricted than the other, we tend to try and bring in a little bit of that particular motion. But I think this oblique axis that we think about is really an important concept of thinking about how does side bend and rotation occur. So, if we go into rotation, how are we going to do rotation? Well, as far as I'm concerned, I think the best way to do rotation is to take a grip on the lower part of the rib cage here, which is exactly the same technique as I do for mobilizing it, to feel on the caudal bone and to let my finger run to the cranial bone. So I'm on the right side of the caudal bone, giving a little bit of sort of stabilization, and my fingertip feels the cranial bone. And as I move back here, I can feel the cranial bone moving into left rotation. The spinous process, of course, going to the right, and I can test that perfectly well. And with my hand across his body here, I'm stabilizing him quite well. Now, I'm trying to give, because I'm rotating a little bit to the side here, I'm trying to not stop any side bend that needs to occur, but I'm not really thinking about the side bend. I'm thinking about, this is the oblique axis, and that is the axis around which I'm rotating. Not that, but more this functional oblique axis. So my push is going to be across here. And this is one of the things that we'll be using when we use this as a mobilizing procedure. And I can come right the way down to L4 and L5. If I'm having a little bit of trouble getting to the bottom, or I've got some hypermobile segments or unstable segments that I don't want to stress, then I could equally well